The kidneys can fail suddenly or gradually. Acute kidney failure is sudden and usually reversible. Chronic kidney failure is sometimes referred to as end-stage renal disease, or ESRD. Sometimes any amount of failure to kidney function is also referred to as renal failure. Chronic kidney disease occurs in an organized or progressive fashion and ranges from diminished renal reserve to renal insufficiency to end-stage renal disease. The kidneys can function without problems until about 65% of the nephrons have deteriorated. The major difference between the two, acute versus chronic, is that acute is reversible and chronic will never improve. The prevalence of ESRD has more than doubled in the last decade. Acute renal failure accounts for about 7% of hospital admissions. Chronic renal failure most commonly occurs from diabetes or hypertension, and acute renal failure most commonly occurs from decreased perfusion. Again, chronic disease has a slow, gradual onset and is permanent, while acute disease happens suddenly and with little warning. Acute renal failure is usually reversible if the underlying cause is treated promptly. Let's do a quick review of the normal anatomy. The kidneys are two bean-shaped organs that sit at the flank with 1 million nephrons in each kidney. Blood from the left ventricle pumps through the renal artery into the glomerulus at a rate of about 125 mL per minute. Filtered blood returns through the renal vein and back to the superior vena cava to be returned back to the right atrium. The final filtrate, urine, collects in the medulla, or center of the kidney, and goes into the ureters, into the bladder, and out through the urethra. Kidneys work all day to filter the metabolites out of the blood. Most of the metabolites are byproducts of protein breakdown. Excess water is removed under the influence of antidiuretic hormone, ADH. Filtration cannot occur without adequate pressure into the glomerulus and an unobstructed flow from the kidneys through the rest of the urinary tract. Without kidneys, it is a matter of a few days before the bloodstream is filled with metabolic wastes, excess water, potassium, and hydrogen. You could live for about a week with no kidney function. The kidney is the water treatment plant. Kidneys receive about 20% of the cardiac output. 125 mLs per minute is filtered through the glomerulus into Bowman's capsule, and it's essential to have a high enough systolic blood pressure. So a question to ponder: what happens if you don't have any kidneys? So here's a metaphor for you. Here's a metaphor for you. You have a cluttered living room that needs cleaning. The filtration in the kidneys is everything in the room that needs to be moved out of the room, and you've thrown it out on the front lawn. Reabsorption, that's the one-by-one junk that is on the front lawn being carried back into the living room. Secretion is equal to most of the junk back in the living room, and the owner of the room decides that a few more pieces of junk need to be gotten rid of, so those few pieces of junk are put back out on the front lawn to be picked up by Goodwill. If there was no reabsorption, then there would be no water left in the bloodstream, and the person would quickly die of intravascular depletion. The nephron is the functional unit of the kidney with a glomerulus, Bowman's capsule, and capillary tubule system. Note that in the end phase, secretion, hydrogen and ammonia are secreted. And also note that water, sodium, glucose are all reabsorbed. Metabolites of protein breakdown and medications are also filtered out, but not reabsorbed. The kidneys are the ultimate homeostatic organ. Fluid and electrolyte balance are regulated with computer-like capability. Metabolic wastes such as urea, nitrogen, and creatinine are filtered out. Electrolytes, such as sodium and potassium, are either retained in the bloodstream or excreted. Blood pressure is regulated through the renin-angiotensin-aldosterone system, and the kidneys also, blood pressure is also regulated through water balance. The kidneys make erythropoietin, which is a hormone that stimulates red blood cell production in the bone marrow. The kidneys make a hormone that allows calcium to be reabsorbed from the digestive tract into the bloodstream. The kidneys will allow for reabsorption of bicarbonate, HCO3, and secretion of hydrogen, which helps maintain arterial pH between 7.35 and 7.45. The main important hormones are erythropoietin, calcitriol, and renin. The kidneys also allow for secretion of used-up sex hormones. Persons with renal failure might take on characteristics of the opposite gender due to an inability to metabolize the sex hormones. Now, nephron function begins to decline after middle-aged years. Nephrons might die off, decreasing the overall size and weight of the kidneys. The glomerular filtration rate, GFR, almost always diminishes to less than 125 mLs per minute, and with a decrease in GFR, toxins are not cleared out as readily. Oftentimes, the older person will end up with a higher than normal creatinine level. The older person might never progress to renal insufficiency, but remain in the first stage of renal failure called diminished renal reserve. In the case of diminished renal reserve, or DRR, there is inadequate reabsorption of water because the tubules do not respond to ADH. Sometimes excess potassium or sodium is lost with all the urine output. Creatinine values are the best determinant of renal function. That's because almost all creatinine that is made through the muscle movement is filtered out, remains in the tubules, and goes out through the urine. Only between 0.5 and 1.5 milligrams per DL is not filtered out. A high creatinine value indicates diminishing filtering ability. BUN can be elevated for other reasons, such as a GI bleed, dehydration, or very high protein diet. When the BUN creatinine ratio is increased, we believe that the patient does not have a kidney problem, but that there is something else wrong, such as a GI bleed, dehydration, or a very high protein diet. The creatinine clearance test is performed frequently to measure how much creatinine is coming out through the urine. We want almost all the creatinine we make to be filtered out through the glomerulus. In the earliest stages of renal failure, lots of urine will be coming out, but little creatinine will be coming out due to the poor filtration of the glomerulus. A decreased creatinine clearance test value indicates that the nephrons are not functioning well. The test involves a 24-hour collection, which starts right after the patient voids or the catheter is empty. In exactly 24 hours, the patient voids one last time, or the catheter is emptied one last time, and the collection chamber is brought to the lab. The container must be kept on ice the whole time to prevent organisms from proliferating, which could confound the results. From that collection, creatinine is measured and a formula is used to determine how much is filtered per minute. All urine must be collected from the toilet, urinal, or catheter bag and placed in a dark container for 24 hours, and that container must always be kept on ice. Serum electrolytes are affected by renal dysfunction. Sodium is often lost since it is filtered out but not reabsorbed. In the later stages of renal failure, when filtration is diminished, sodium and potassium are not filtered out, and these levels become high. As renal failure progresses, calcium levels go down and phosphorus levels go up. Phosphorus is not filtered out through the poorly working glomerulus. Calcium and phosphorus are inversely related. The higher the phosphorus level, the lower the calcium level. Calcium is low because the kidneys fail to make one of the vitamin D hormones, calcitriol. Without this hormone, calcium that we eat cannot be absorbed from the digestive tract into the bloodstream. Patients with renal disease tend to be low in calcium. A common early sign of renal disease is to have dilute urine with a fixed specific gravity of 1.010, which is quite low. This is because the kidneys do not respond to ADH. The measure of specific gravity lets us know how ADH is working and whether the patient is retaining fluid or losing it. The arterial pH is influenced by the kidney function as well. With renal failure, hydrogen ions are retained and bicarbonate is lost. Many renal failure patients will be acidotic. Sometimes the pressure of CO2, PCO2, will be low because the renal patient will be breathing extra heavily to get rid of acid via the lungs. This is called Kussmaul respirations. Most commonly, patients with kidney disease will have metabolic acidosis with or without respiratory compensation. The pH will be low with the kidney disease because hydrogen ions are retained while bicarb is being wasted in the urine. The patient might hyperventilate to get rid of acid through the respirations, Kussmaul respirations, and bicarb is low because it's allowed to be secreted into the urine. In the case of metabolic acidosis, hyperventilation is a compensatory response. In pathological hyperventilation, which causes alkalosis, breathing into a paper bag can help. Pre-renal failure involves anything that can happen between the heart and the kidney, or from the heart to the kidney. Typically, this involves a situation of hypoperfusion. Examples of hypoperfusion are third spacing, hemorrhage, heart failure, or dehydration. Another cause is a blockage between the heart and the kidneys, such as a thrombosis in the renal artery. Intrarenal acute renal failure involves anything that damages the nephron tubules. Classic examples include the use of nephrotoxic drugs such as ketorolac or Toradol, vancomycin, or the contrast agent used for CT scans. Also, burns or crushed muscle cells can release myoglobin that can lodge in the kidneys. This can happen with serious burns and lead to This can happen with serious burn injuries and rhabdomyolysis. Antibody-antigen complexes that result from the inflammation and infection can also lodge in the tubules, creating damage that can happen with antibody-antigen complexes that result from inflammation from infection can lodge in the tubules, causing damage, as can happen with glomerulonephritis. Post-renal acute renal failure involves anything that obstructs urine flow from the kidneys to the urethra. Obstruction from a stone in the ureter can block the urine flow out of the kidney. For men, benign prostatic hypertrophy, BPH, is common and can block the flow out of the urethra. Even something as obvious as a blocked urinary catheter can cause acute kidney failure. So what are the causes of renal failure? Diabetes, well, for chronic diabetes, hypertension, glomerulonephritis, lupus, and polycystic kidney disease. For acute renal failure, renal stones, burns, blocked urinary catheter, low cardiac output, and CT dye, vancomycin, or ketorolac. Polycystic kidney disease is a hereditary condition leading to cyst formation and thrombosis of kidney tissue. Eventually, the patient with this condition will end up with chronic kidney failure. Acute renal failure progresses through 4 stages: initiation, oliguria, diuresis, and recovery. In acute renal failure, at the first, the urine output will diminish. Urine output will be less than 400 mLs in 24 hours and might even diminish to nothing. Once the precipitating factor, cause of the problem, is gone, there will be a large amount of output as the nephrons begin to filter like crazy. It's as if a plug was released from a filtration system. Once a patient has had acute renal failure, they are more prone to developing it in the future. With acute renal failure, urine output diminishes to almost nothing and then progresses to diuresis once the cause is fixed. The patient with ARF has many signs and symptoms of a patient with CRF, but there will be a rapid onset with ARF, acute renal failure. The most severe sign of renal failure is hyperkalemia, because high levels of potassium can lead to lethal dysrhythmias. Acute renal failure is treated by treating the cause. For example, a patient might go into pre-renal kidney failure due to severe dehydration. The treatment would be simply to give the patient lots of intravenous and oral fluids. Hyperkalemia, high potassium levels, goes with the renal failure. There are various ways to get rid of excess potassium, including the use of the drug Lect08, a dextrose insulin combination, or a diuretic like furosemide, Lasix. If the potassium can't be diminished by one of these routes, dialysis might be even necessary to save the patient's life. Chronic renal failure is progressive, irreversible kidney damage with progression from diminished renal reserve with polyuria to renal insufficiency to end-stage renal disease. Consequences of chronic renal failure include fluid overload, retention of urea, creatinine, potassium, hormone problems, deficiency in erythropoietin, phosphorus retention, and insufficiency of hormonal vitamin D. In diminished renal reserve, there is a large amount of dilute urine. Everything is filtered out at the nephron, but there is a failure to reabsorb back into the bloodstream. As there is a progression to renal insufficiency and finally to ESRD, there is a total failure of filtration. When there is 10% or less nephron function, the patient must have dialysis or a transplant, or the patient will die. In diminished renal reserve, which is diagnosed through a 24-hour creatinine clearance test, the patient will have probably no signs or symptoms because the other 50% of healthy nephrons will compensate. But urine output will increase as tubules stop responding to the ADH and reabsorption decreases. Specific gravity will decrease and the patient will have nocturia and polyuria. With renal insufficiency, the patient will have a gradual increase in serum creatinine and oliguria as the unaffected nephrons can no longer compensate and filter properly. Hyperkalemia creeps in as oliguria progresses. End-stage renal disease occurs when there is less than 5 to 10% function. In this case, it is incompatible with life and the patient will quickly develop severe azotemia or uremia, fluid overload, and hyperkalemia. The patient is dependent on dialysis or transplant. Dialysis has been paid for by Medicare since 1972. Every system is affected by failing kidneys as byproducts of protein metabolism accumulate and hormones go awry. There are cardiovascular changes. The patient will have hypertension due to the outpouring of the hormone renin, which stimulates aldosterone, which in turn causes sodium and water retention. Renin also causes vasoconstriction. Pericarditis, inflammation of the pericardial sac, occurs due to circulating toxins that irritate the tissue. Heart failure and pulmonary edema occur because of excess fluid being retained and not secreted by the kidneys. There are neurological changes. Normally the protein we eat is broken down by the liver and the byproduct of ammonia is made. Ammonia is filtered out of the blood by the kidneys. The renal failure patient retains the ammonia and it gets into the brain, causing ataxia, which is an unsteady gait, asterixis, a flapping of hands, and confusion. Integumentary changes. The skin takes on a yellow discoloration, icterus, due to the inability to filter out bilirubin. The patient is anemic and pale, and along with the icterus comes pruritus, or itching. There are pulmonary changes as well. With a lot of fluid overload, the patient might end up with a pulmonary edema. The patient might also have deep, rapid breathing in an attempt to get rid of the acid, cause small respirations. With the GI tract, there are changes as well. Patients with renal failure often develop nausea and loss of appetite due to the retention of the metabolites. Think how you feel when you've eaten a lot of junk food and you just can't get rid of it. They have a sweet, musty smell of their breath, a uremic fetor, and there are sores in the digestive tract from the irritation of the circulating metabolites. Hematological changes. The toxic bloodstream makes it difficult for the blood cells to survive. Red and white cells, platelets, die sooner than normal. Patients are anemic due to the deficiency of erythropoietin, and loss of blood occurs with each dialysis session. Reproductive changes. Ordinarily, the kidneys would filter out unnecessary hormones, such as testosterone for females and estrogen for males. Males can develop breasts, and females will have the loss of a period. Both genders lose the ability to reproduce. As far as musculoskeletal changes, there's renal osteodystrophy, which occurs when the calcium is taken from the bones and put into the bloodstream. The parathyroid hormone is responsible for maintaining normal blood calcium levels. The parathyroid gland goes into overtime to work to keep up with the calcium level that is chronically low. The patient will have brittle bones and muscle cramps because the muscles are constantly deprived of calcium. Lab values change for chronic renal failure and are the same for acute renal failure, but occur more gradually. Their ABG is acidotic. They are hyperkalemic. The specific gravity is low due to leading to a diminished renal reserve and high for end-stage renal disease. Their calcium levels change. They're hypocalcemic. Phosphates are high, and the red count is low. Renal patients receive drugs to bind the phosphorus out of the bloodstream and into the digestive tract, which in turn lowers phosphorus and raises calcium. Renal patients all get erythropoietin replacement to stimulate the bone marrow to make red blood cells. A variety of antihypertensive drugs are also needed to combat the renin, angiotensin, aldosterone system that can take over when the kidneys fail. Once the patients are down to 5 to 10% of their kidney function, dialysis is required. The kidneys fail gradually, and there might be a period of time where the patient copes with the gradual loss, and then finally there are so many problems such as hyperkalemia, hypertension, anemia, and fluid overload that the patient has no choice. Dialysis works by diffusion, particles moving from concentrated to less concentrated areas, osmosis, water moving from more watery to less watery areas, and ultrafiltration, patient's blood being pumped with force past a dialyzer, causing the particles to be shoved into the dialysate. The key components of hemodialysis include vascular access, the dialyzer, which is the artificial kidney that contains a porous layer which mimics capillary walls and also contains the dialysate. The dialysate is a solution that flows through the dialyzer past the blood. Dialysate is a concentrated solution allowing water and some electrolytes to move into it through osmosis. Anticoagulation is added to the system so the blood does not clot as it travels outside the body. Heparin is usually used. There are three major types of vascular access devices used for dialysis. It is essential to protect these devices because they are the patient's lifeline. The best access device is the arteriovenous fistula. Many patients can't have fistulas because they don't have suitable veins. In this case, a piece of Gore-Tex can be stitched in to attach an artery to a vein. This is also called a graft. The non-tunneled central dialysis catheter might be placed in the operating room to provide immediate access. The dialysis catheter does not get a great blood flow and is really only ideal for short-term use. The dialysis catheter might be inserted into the subclavian, femoral, or jugular vein. So 44, it's a radial artery arterialized cephalic vein. The fistula is created by attaching the artery to vein, and this gives access to stick the vein with needles while still getting the flow of an artery. When a patient has an AV fistula, it's very important to touch it to feel for a thrill, which is a sort of a thrumming sensation, and to listen to hear for a bruit, which is the turbulence of the mixing blood. A positive thrill and a bruit mean that the fistula is working. The AV fistula is the patient's lifeline, and an AV fistula must be protected so that never bother that arm. Simply assess the AV fistula and that's it. In hemodialysis, blood is pumped out of the artery, filtered through the dialyzer, and then returned through the vein. The patient's weight and blood pressure must be recorded before and after every dialysis session. Many drugs are not given prior to dialysis because they will be dialyzed out and rendering them useless. Antihypertension meds are also generally not given prior to dialysis because they can cause the patient to have the dialysis session with too low a blood pressure. What are the complications? The complications of dialysis include disequilibrium syndrome. This is most likely to happen when the patient first starts dialysis and toxins are removed too quickly, and the fluid can rapidly shift into the brain cells. The patient becomes delirious and might even have a seizure. Anemia will become more pronounced with dialysis due to red blood removal, so erythropoietin is really needed. There is a risk for bleeding due to the use of the anticoagulants, and patients will have a somewhat elevated temperature due to the use of warmed-up dialysate. Temperature is not a problem until it gets over 38.5 degrees centigrade. In disequilibrium syndrome, the patient will have double vision, headache, loss of consciousness, and could even have seizures. Peritoneal dialysis allows for the removal of excess toxins and water through the peritoneal cavity. The space around the abdominal organs, the peritoneal cavity, holds the toxins and excess water. The peritoneal membrane serves as the filtering area. The peritoneal space is filled with dialysate and toxins and waters diffuse into the cavity. The patient will have a catheter coming out of the abdomen. The fluid gets drained out of the catheter and into a bag, and then a new bag of dialysate is run into the peritoneal cavity. The fluid sits there and waits until it is drained again. So, drain first, then infuse, dwell, and drain again. There are many complications that can occur with peritoneal dialysis. The most common is peritonitis. That's because of the high sugar concentration that sits in the peritoneal cavity. The patient and caregivers have to be very careful about the peritoneal catheter. Sometimes the patient can't get fluid in or out. Obstructions can occur due to clots or compression on the peritoneal catheter from the abdominal organs. It is important to prevent constipation. The patient might have pain in the beginning, but will get used to the flow. The patient might be hyperglycemic due to the high sugar content in the dialysate. Renal diet. The patient on peritoneal dialysis has much more freedom to eat whatever they want except for glucose. The patient on peritoneal dialysis can filter out toxins throughout the day. Patients who are in renal failure, who are not yet on dialysis, are more restricted. And the patient on peritoneal dialysis must watch their sugar intake because of the high sugar concentrations in the dialysate. The patient might opt for a kidney transplant. The patient might receive a kidney from a cadaver or a living related or unrelated donor. The new kidney is sutured in, and the old non-working kidney is simply left in place. Once the patient receives a kidney, he or she will have an alloimmune response, so it is essential that the patient consistently takes immunosuppressant medications. And they will need to take these medications as long as they have the donor kidney. Whenever you are faced with a question about transplants, remember how critical it is that the patient understands that they will always have to take their anti-rejection medications, prednisone, Prograf, Gengraf, Cellcept. Finally, the problem with anti-rejection meds is that they suppress the immune system, leaving the patient open to infection. Patients on these meds often have frequent hospitalization for opportunistic infections. Drugs such as prednisone or a corticosteroid cause the release of sugar from the liver, turning the patient into a diabetic.